and welcome to Let's Talk CNAs, a show for CNAs by CNAs. I'm your host, Wendell, and this is my lovely co-host, Angel.
Hello, and we are here in Phoenix, Arizona.
Yay, yay!
And today's topic, we will be talking about occupational therapy.
Occupational therapy?
That's right, Wendell. And did you know that occupational therapy was founded in 1917 in World War I?
Wow. And also, Angel, did you know during the 1980s and 1990s, occupational therapy began to focus more on a person's quality of life in order to achieve a state of health during occupation?
Wow, that's awesome, Wendell.
Right. Well, Angel, are you ready to start the show?
I sure am.
All right. Well, in that case, let's
have a conversation. Let's talk CNAs. Let's talk CNAs. Let's talk CNAs. Okay. Let's have a conversation.
Thank you for being on the show.
You're welcome. Thanks for having me.
So, Ms. Nita, tell us a little something about yourself.
Okay. I have been an occupational therapist for 40 plus years, and I've worked in various areas of occupational therapy. I'm from back east, so I started off working in psychiatric hospitals with adults, and then with children in treatment centers.
Okay.
And then when I moved out here, I started working in the schools. So I worked in the schools for about 4 school years, and then after that I went into the skilled nursing facilities and did some home health. And I've been working in long-term care, such as like Maravilla, for close to about 20 years. Not all on a full-time basis, though. So anyway,
Well, your reputation precedes you, so awesome, great job.
Oh, thank you.
Yes, you've been through all aspects of healthcare. That's awesome.
Yes, occupational therapy is very diverse, you know.
Right.
You can work in all kinds of settings.
Well, Ms. Nina, as you know, we have what we call a $1 million question. So 50 CNAs wanted us to ask you, what's the difference between occupational therapy and physical therapy?
Okay, that's a good question. I know a lot of people confuse the two disciplines, but we do overlap, and sometimes that's where the confusion comes in. But the occupational therapist helps the patient to regain their independence in doing their ADLs or activities of daily living skills. And in order to do that, we work on building up their strength and their endurance and their range of motion, increasing their range of motion, as well as improving their coordination so that they could perform their activities of daily living skills better. And the occupational therapist works with anything that involves the hand. For instance, if the resident have hand contractures, the occupational therapist will recommend a splint and provide a splint. Now, the physical therapist works primarily on lower body strengthening, ambulation or gait training, balance and transfer training. And that's one of the areas that we overlap in transferring the patients, teaching them how to transfer safely, as well as balance. OT works on balance, standing balance, so that they'll be able to stand at the sink to perform a task or do their dressing, putting on pants and things of that nature.
Okay.
Awesome.
All right. Well, thank you for answering that question for us, Ms. Nita. And that was a good question, and I hope your question was answered. Very good question, Ms. Nita.
Yes.
So, Ms. Nita, I know we're going to just go right off into this about occupational therapy. How do OT help residents regain their independence?
Well, the occupational therapist teaches the residents compensatory strategies or adaptive ways. Particularly, it depends upon what their deficit areas are. So we focus on helping them to be able to dress themselves better. For instance, if there is a stroke patient and that patient has limitations on one side of the body, don't have any active movement or may have a little bit of active movement, then we teach that patient how to put on a shirt or take off a shirt using adaptive strategies. If the patient has difficulty with gripping, like gripping a utensil, which would interfere with their ability to feed themselves, we might give them an adaptive device to use, like a built-up spoon or any kind of utensil or a lip plate or things of that nature.
Okay. All right.
So, and we work on the toileting as well,
Oh,
and helping them to be
That's
independent with toileting
that's a big
and
thing.
any aspects of the self-care.
Right. So would that be something? Would you still go off of the theory of when you're addressing someone, you're addressing the weak side first? Is that still part of what the occupational would teach?
That's correct. That's correct. You always want to address the weak side, the weak extremity first. But when you get undressed, you undress the weak extremity last. Okay.
Okay. All right.
First and last.
Yes.
Okay, and I know a lot of times as CNAs and caregivers, we tend to wanna, even when they're going through occupational therapy, that we wanna go ahead and do it. But a lot of times the occupational therapist will say, hey, don't do it for them. This is a part of their therapy, so help them with their therapy. What would you say to, caregivers and CNAs to where they can kind of let them, what should we do?
Yes, that's what you just said. If the resident is able to do the task himself or herself, then allow that person to do it, okay? Because this helps to build up their self-esteem and gives them a sense of self-worth if they're able to do the task themselves instead of, instead of a CNA doing it for them. Yeah, we want them to, if once they have progressed in therapy and they've reached a point where they could do it themselves, and if they're safe in doing it, then please allow them to do it. I know sometimes the CNAs, particularly in the mornings, are, they're in a rush to get the patients up and into the dining room. But if there is a patient who is fairly independent and safe, you could just set them up and leave and come back and check on them to see how they're doing. Yes.
So. What, Angel kind of hit on this a little bit, on this next question, but I know with my grandmother, we did our best to make sure that she maintained her independence, but at the same time, we just wanted to help her, and I guess that was just as a loved one. I can't necessarily say as an employee, because it was my grandmother, but we just wanted to do all these things for her because we wasn't accepting that, she was having this hard time or she couldn't do certain things. So, but as a CNA, how would you say we can help with that therapy process?
Well, as again, just giving the patient time to do the task. Okay, I know it's very hard to stand back and see somebody struggling. If the person is struggling, then you step in.
Right.
Okay, but allow them to at least try it. And if you see that they're having difficulty, you can do it. That's okay. Yeah.
All right.
So.
All right. Well, Nina, I'm going to go into my next question. It's kind of like that, but what are the customized treatments of occupational therapy?
Well, first, it starts with an evaluation. We get an order from the doctor to evaluate. We cannot evaluate without an order. So we evaluate the patient, and that evaluation process consists of a brief interview asking the resident or patient or neighbor, as it is at Maravilla, what their prior level of functioning was. If they came to the facility directly from home or either from the hospital, and they were independent within their home environment, that's good. If their prior level of functioning was independent, then we work on trying to help them to regain that independence. If, however, they were not independent at home, we just work on those skills that they were able to do. So once the evaluation is done, assessing the range of motion, the strength, the coordination, assessing their ability to follow directions, because in order to learn, you have to be able to follow directions.
Right.
Assessing their mental status in terms of being able to retain information. A lot of dementia patients, can't retain information, and there's no carryover
Right.
if the therapist is trying to teach them something. So once the evaluation is completed, specific goals are written
Right.
for that patient based on the deficit areas that have been identified, and the goals are specific and measurable, so that we could really determine whether the patient has made progress.
Awesome. Okay.
So it definitely have to be basically tangible goals.
Yes.
Right.
For each part of therapy. I
Yes.
would say, yeah.
Mhm.
Okay. So I know that you have a lot of devices here that you want to show us. So we're going to take a small break, and when we come back, we're going to look at some of the devices that Miss Nina has to show us. Okay? Be right back.
Can you demonstrate some of these devices that we have here today?
Okay, I will tell you about the devices, and maybe I can get Wendell to demonstrate that for one of them later on.
I'll be happy to.
But anyway, these are devices that we use for residents who have a difficult time lifting their leg to put their shoes and socks on or pants on. So I'll start with the dressing stick. You could use this stick to push the shoes and socks off using this end, and this end you could use to put the pants on. And the other end, which is like a cup hook end, I generally have the patients to pull their socks up, particularly after using the sock aid and the sock doesn't come up all the way on their foot or leg. They could use this to pull it up.
Wow, I always thought it was for hanging up on the on the hook.
Well, yes, it could be used for that too. Okay, and this is the reacher. Everybody knows what the reacher is. Yeah. The reacher is used to put your pants on, pants under pants or whatever. And this in here you could use to push your shoes off with.
Oh, wow.
Okay. And also, the reacher is used to pick up things from the floor that you should call drop, or get things out of the closet or cupboard. So this is a very good piece of equipment to have in your home. Anybody. I have one in my house, and I use it every now and then.
Yeah, they definitely come
to
in
get
handy.
things that are out of my reach. Yeah. And this is the long-handled shoehorn. There are two types here.
Okay.
The longer one.
Taller person, shorter person.
That's the way you could look at it.
Right.
Yes. All right. So we put shoes on with this, and the sock aid. The sock aid to put the socks on. Particularly, people who have difficulty lifting up their legs because of limitations.
Okay.
Okay.
All right.
All right.
All right. So, Miss Nina, I've been watching these two. I mean, I understand that they'll play this one and then they'll play. We're going to come back to it, but this is the one that's caught my eye because I've noticed that these two utensils are heavy and these are light. Can you tell us what's the reason for that?
The heavy utensils are for those patients who might have tremors. They might have fine tremors due to Parkinson's disease or some other medical condition. So we have them to use a heavy weighted utensil, which will help to control the tremors.
Okay.
Sometimes we might put a weight on their arm to help control tremors. But anyway, if the tremors are really bad, you don't want the resident to use a fork.
No.
Right.
So the resident would always use a spoon if they have really bad tremors. The light weighted built-up utensils, are for those residents who have decreased grasp. They cannot really hold the regular utensil adequate, so we give them the lightweight.
Okay.
And
That's
this is also used if you don't have the not weighted, but built up utensils. This little rubber tubing can help build up the utensil by sliding the handle of the utensil in here so that they could hold it better.
All right.
All
That's
to-
awesome. That's awesome. So what is, this is a deep, what would you call it, a parade deep plate divider or something like that? But
Yeah.
what is that one?
Yeah, the divided plate is always good, and this one is, extra deep. Yeah, it's always good, particularly, it's really ideal, I think, for those patients who might have some visual impairments.
Right.
So that they could separate their food and know where their food is.
Okay.
And sometimes residents might be on a parade diet and they don't like their food all together. So using a divided plate could help satisfy that issue. And then there's always the lip plate. Everybody knows that. We recommend lip plates when the resident might be pushing their food.
It's not a cover.
Yes.
Yes.
All right,
Yeah.
Miss Nina.
When the food is being pushed off of the regular plate, then a lip plate is recommended.
Okay.
That helps
Okay.
for not the food being on your lap.
Right. All right. Miss
Yes.
Nina, our producer's telling me we have about 15 seconds left. Can you tell us about these last 4 items real quick?
Okay, these are some orthotic devices that we use for hand contractures. This one just is like just a hand roll that you can put in the resident's hands to help preserve skin integrity so that they won't be digging their fingers in their hands. And also it helps the CNAs to clean their hands up better. And these two are just resting hand splints.
Right.
This one is more is color coordinated so you can know where to place the straps. This one is a carrot. It's used for those severely contracted hands.
Right.
So you just push it in the hand so that the resident can have something in their hand, and that also helps to increase their range of motion gradually.
All right.
Okay.
All right. Well, this is very awesome. I love these items, and I look forward to seeing some of these items being used at the facility. I mean, I know about the reacher.
I'm taking that home.
Hey, I even know about the hook.
Yeah.
Yeah, so once these, once the therapist gives these items to the patient to use in their rooms, so it's important to encourage the patient to use it instead of just leaving them in the closet.
Exactly.
Okay.
Or hanging it on the curtain.
Yes. Okay, I'm going to show Wendell how he could take his socks off and put them back on. Just the one sock, though. Okay.
right.
So this is the dressing stick Wendell is going to use. He's going to that part that's sticking down. Stick it in the center back of the sock. And you want to get it off of your heel. You might want to put it here again.
Like right here?
Center, more center.
What's it there?
Take your time.
On the back of the heel.
Oh, the back of
Yes,
the heel.
yes.
Oh, okay. Okay, the
Yeah,
heel.
there. Once you get that heel off, it's easy to
Oh, like that. Oh, cool.
get it.
I wear
And-
2 pair of socks, y'all, so don't be saying
Yeah, you have to put the sock back on. So
Oh, I have to
remember,
put it
you can't
on.
bend and you
Oh,
can't
okay.
lift your leg up. You have a
Okay.
hip fracture.
Oh.
Okay, pop it against your belly.
Okay. Like so?
Yes,
All right.
and take the end of the sock and just pull it up on the sock
Okay.
aid. Make sure the heel is in the center back.
Okay. Like so?
Yes,
All right.
You got it pulled up to the knots. Okay,
Okay,
that's
yeah,
good.
up to the
Good,
knots.
and there's no space in the toe.
No,
Good.
ma'am.
So you want to hold on to the ropes, one in each hand, and toss it out.
Like so?
All right. And slide your foot all the way down before you start pulling on the ropes, because if you pull on the ropes too soon, the sock won't go but halfway on your foot. You got it.
Pull on the ropes.
Pull.
Wow.
Okay. All right.
Wow.
Okay. So you can either take the reacher or, and it looks like the heel isn't.
Oh. We'll fix that here. Watch this. I got a reacher. Inspector Gadget. Woo. Woo. Pull my pant legs up. My hip is not moving, y'all.
And you're not bending more than 90 degrees
See?
to do that. Okay.
There we go.
All right.
Slowly but surely.
Particularly if the patients want to be independent in doing this, if they're going home and living alone, this equipment is good to have. And if they're in the nursing, long-term care facility, the nursing home, and they want to be independent, this is,
all right.
this is what we
Get y'all
recommend.
a reacher. If you at home, get a reacher.
All right.
All right. Well, thank you, Miss Nina.
You're quite welcome.
Miss Nina, is there any last words you would like to say to CNAs and the audience here?
Okay. My last words are that the CNAs, they do a fantastic job.
Yay.
You know, they do excellent work and hard work. So I commend them. I commend them for the work that they do. I just want to stress to allow the patient to do the task if they are capable of doing it, and if they are safe in doing the task. Allow them to do it. A lot of times I've worked with patients and I've gotten them to the point where they could feed themselves, and then I come back and I see the CNAs feeding them. So that's a disappointment. But anyway, CNAs, I love you, and you do a fantastic job. So allow the patient to do as much as they can on their own.
Independence is the key.
Yes.
Believe me, I done got scolded on that by the
Okay.
All right. Well, thank you for being on the show, Nina.
You're quite welcome, and thank you. Thank you for having me.
All right. Well, Angel, we had another great and informative show.
We sure did, Wendell. And make sure you all check us out on YouTube, Instagram, Facebook, and Twitter.
That's right. And we would like to thank our special guest, Miss Nina, for being on the show. And we would like to thank you for watching the show. And we'll see you next time on Let's Talk CNAs, where knowledge is empowerment. Let's have a conversation.
Let's talk CNAs. Let's talk CNAs. Let's talk CNAs. Okay. Let's have a conversation.